Okay, let's talk about osteoradionecrosis. I found these two papers, which I'll link below in the description if you want to read them yourself, which are both kind of nice reviews of the current state of our knowledge on osteoradionecrosis. Start with this paper. So, osteoradionecrosis basically is this necrosis, usually of the mandible, which is the jawbone, after radiation. It occurs usually within the first 3 years, and about 5 to 15% of people that undergo radiation experience osteoradionecrosis. Now, this 15% number is pretty high. With modern IMRT radiation techniques, it's probably close to 5%. 5% is the expected number of people that experience osteoradionecrosis, and most of these will occur in the first 3 years. And what happens is people end up with this area of exposed bone that doesn't heal, and then the bone starts to die, and the lesion usually expands, and then it can lead to it's very painful, and it leads to bad breath, infections in that area. It can lead to a fistula where the dead bone goes out and drains out into the skin. It can cause pathologic fractures. The bone gets so weak it just breaks from trying to chew or talk, and that results in like malocclusion. Teeth don't fit together right. Trismus, you can't open your jaw very wide. And so there's a couple of factors that determine why some people are more likely to get osteoradionecrosis versus less likely, and that is dependent on dose of radiation. So more radiation, obviously, higher chance of ORN. How much of the mandible gets the high radiation? So if a small area gets radiated, then you're less likely to get it. If a large part of your mandible gets it, more likely to get ORN. And this is one of the reasons that if your cancer is on the mandible, generally that treatment is surgical. We'll do surgery to remove it rather than radiate it, because if you radiate cancer that's on the mandible and you have to deliver that kind of dose of radiation to the mandible, generally you're going to have bad side effects like ORN. And also, it's not very effective when radiation is not as effective when cancer invades into bone. Then if you have chemotherapy along with the radiation, that increases your risk of ORN. The volume, so larger tumors, more radiation area, that just makes sense. If you've had tooth extraction relatively soon before the radiation starts, so this is why if you are planning on getting radiation therapy, it's best to get a dental evaluation as soon as possible and get the teeth taken care of as soon as possible, so that you can have some time for the tooth sockets to heal before radiation starts. So, because that needs to happen. If people have bad teeth or teeth that need to be taken care of, that needs to be taken care of before the radiation starts. Because if radiation happens while they have bad teeth, then you're going to get problems with that. And then malnutrition is a big factor, and unfortunately, many head and neck cancer patients are malnourished because it's the tumors in the mouth and the throat cause pain, and people have dysphagia. They don't want to eat, and so they usually have weight loss, and they haven't been eating the healthiest foods up until then. So it's very important to try and maintain good nutrition, healthy food, and then poor oral hygiene. So that's obvious why that would cause problems with osteoradionecrosis. And then alcohol and tobacco use is a problem for it. So a lot of head and neck cancer patients they get their head and neck cancer because of alcohol and tobacco use, and so it's important to stop that as soon as possible before treatment to avoid these complications. So actually, I read through this paper, and it's very good, but it's very dense on the basic science, which I think if you're interested in the actual pathophysiology of it, it talks about all the growth factors and the intracellular pathways, but that's probably a little more detailed than most people are interested in. So this paper is a little bit more concise and doesn't delve into the nitty-gritty of like the intracellular pathways and growth hormones and such. But basically, the thought process is that initially people thought that it was just an infection of the bone, that it was something called osteomyelitis, which is just an infection in the bone. But then we realized soon thereafter that it's not just an infection, because if it was an infection, we could just treat it with antibiotics, and then that would take care of the problem. But that doesn't work. Now, you can get osteoradionecrosis and also have an infection, in which case you do need to get antibiotics. But the infection is not the osteoradionecrosis. In '83, Marx came up with this theory that it was actually you're losing vascularity in the bone, which leads to hypoxia, which is no oxygen in there, and that leads to less cellularity. So less blood vessels, less oxygen, less cells. Then you have poor healing, and then you have osteoradionecrosis. More recently, Delanian has this thing called the radiation-induced fibroatrophic theory, and this basically says that the radiation causes this the fibroblasts, which are these connective tissue cells that are all over our body, them to be dysregulated, and that's all the intracellular pathway stuff that they talk about in this other paper. But basically, the fibroblasts do not act normally, and they cause fibrosis where you don't want it, and it causes poor healing. And that's led to this kind of relatively newer way of treating it that is the way that I've been treating it more recently, and is the way that people are treating it now. So on the prevention end, what we need to do is work on reducing radiation dose to the area through good radiation techniques. So a good radiation oncologist is important. And then two, improve nutrition as much as possible, and take care of your teeth as soon as possible once you get a diagnosis, so that the teeth can be taken care of and the tooth sockets can heal before the initiation of radiation. Work on the eating as healthy of a diet as possible before and during therapy. And then you got to stop the smoking and the alcohol as soon as possible as well, because those are things that will prevent this problem. Now, once we have the problem, how are the ways that we're treating it? So there's a couple of major methods. One big thing is hyperbaric oxygen, and that is kind of one of the mainstays of therapy. There's not very good data to support it in terms of randomized clinical trials. All the trials have been kind of small number, not very well controlled, and so all the studies seem to say that it works, but it's not clear how good the data is, because we don't know how well the studies were run. They have some problems in selection bias and how they grade it. So some of them are working with small, easy to treat lesions of osteoradionecrosis. If you give those hyperbaric oxygen and they seem to do better, maybe they would have just gotten better anyway. So it's not clear whether that's that helpful. The other thing is this, because of this new radio-induced fibroatrophic theory, people are using a combination of 3 drugs, and they are pentoxaphene, tocopherol, and clominate. Pentoxaphylline, let me see, where is this? Yeah. Pentoxaphylline. I don't know if I'm even pronouncing that right, but that's an antifibrotic drug. And then tocopherol essentially is vitamin E, which is an anti-inflammatory, antioxidant. And then clomate, that's a bisphosphonate. It's similar to the drugs that they use to treat osteoporosis. So a 3-drug combination of that has been tried, and it seemed to help. But this was an uncontrolled trial, so there wasn't any placebo group. So what they need is a randomized clinical trial where you have a placebo group to see if this actually works, or if it just seems to work just on placebo effect. But this is the thing that we do, because until the randomized trial happens and it proves that this doesn't work, this is the way that people are going to treat it, because we don't have a better method. So my initial strategy for treating my patients with ORN is to try this combination, and then if this fails, then we go to the hyperbaric oxygen. If that fails, then we do surgery. And surgery is essentially you replace the radiated bone with bone that has not been radiated. So the area of osteoradionecrotic bone is resected surgically, and then we take either rib or fibula. Fibula is the small bone in the lower leg. Or sometimes I guess we could use iliac crest or scapula. I don't do free flaps, but I have many partners that do free flaps. So I will resect the bone, and then one of my partners will put in the free flap, and that almost always works. But that's a long and fairly arduous surgery to undergo to treat this thing. So those are the three major ways to treat it. Is this drug combination, the three drug combination, and if that doesn't work, we try hyperbaric oxygen, and then if that doesn't work, we do the surgery, and that almost always works. This is an interesting paper that is just a basic science paper where they looked at the bone vascularity after radiation, and indeed they found that vascularity goes down in the bone as expected. So that is, the major problem is there's just not enough blood vessels there. That is one of the major findings. We don't know if that's the cause of it or if that just happens to be another finding that's unrelated to the osteoradionecrosis. And then this is a good paper, which I also link, that kind of reviews all the pentoxifylline and vitamin E studies that have been done over the years. And basically, the end is that we do need a randomized control trial for this, and I believe that is ongoing actually right now. So that's good. This is actually, when I was researching this right now, this was something I found which was actually quite surprising to me. They've just finished a randomized control trial of hyperbaric oxygen to try to prevent osteoradionecrosis. So what happens is, because no one wants osteoradionecrosis, when people are undergoing dental work, dental extractions, or dental implants after they've had radiation, I have always recommended that people get hyperbaric oxygen before and after their dental work to try to prevent osteoradionecrosis. That's what I've been taught. That's what everyone does. And that is kind of dogma in our field. And this trial looked at 144 patients, and they randomized them to get hyperbaric oxygen or not get hyperbaric oxygen before they had some dental work. And what they found out is that at 6 months after the dental procedure, there was about 6% incidence of osteoradionecrosis in both groups. So it did not seem to make a difference. So their conclusion is the low incidence of osteoradionecrosis makes recommending hyperbaric oxygen for dental extraction or implant placement in radiated mandible unnecessary. So it made no difference. These findings are in contrast with the recently published Cochrane review and previous trial reporting rates of ORN without hyperbaric oxygen of 14 to 30%. So in previous studies that were not as large, not as well controlled, they found 14 to 30% incidence of ORNs, which is pretty high. And so people were wanting to do the hyperbaric oxygen to prevent it. And this challenges a long-established standard of care. So they understand that this is not what everyone does. Everyone, what they do is give them hyperbaric oxygen. But they are saying that's unnecessary. Now, the question for me is this going to change my practice? Am I going to stop recommending hyperbaric oxygen? This is a really good trial, and so I should believe it, but it's very hard to make people change their practice. I haven't decided what I'm going to do with this information. I'm probably going to recommend it for people that I'm kind of more afraid that they might get osteoradionecrosis if they've had higher doses. Maybe I'll not be so dogmatic about recommending it for people that haven't that haven't had such large doses and their mandible looks fine, because the data says that it doesn't make a difference. So hopefully someone repeats this. If they get another randomized trial that supports this information, then I think people will change. So to sum it up, the things that we need to do before treatment is good nutrition, Take care of the dental issues as soon as possible so that it has a chance to heal. Stop smoking and drinking. And then afterwards, the treatment options are pentoxifene, tocopherol, and clominate combination. And then if that fails, then we do colondronate. If that fails, then we go to hyperbaric oxygen, although the effectiveness of that is now somewhat in question because of this trial. If that fails, then we do free tissue transfer with non-irradiated bone, and that almost always works. But yeah, this was a pretty surprising study that changes dogma. Okay, so I hope that was helpful. If you have any questions or comments, please comment below, and thanks for watching.